The presentation today will cover gastrointestinal disorders. My name is Bethany Von Hoff, and I will be the presenter today. We will be discussing two of the most common disorders impacting the gastrointestinal tract. They are GERD, or gastroesophageal reflux disease, and PUD, peptic ulcer disease. For both of these diseases, we will talk about how they are classified. We'll talk about lifestyle or non-pharmacologic treatments, as well as pharmacologic treatments available for these disorders. We will begin by reviewing the useful abbreviations as well as introductions to the disorders being covered in this presentation. The first is GERD, or gastroesophageal reflux disease. This is commonly referred to as heartburn. It is a minor irritation, generally higher up in the GI system or the esophagus, and it can lead to worse outcomes if it's left untreated. There's a sphincter at the bottom of your esophagus called the lower esophageal sphincter that separates your esophagus from your stomach. Anything that causes the sphincter to be loosened or to allow material to flow backwards from the stomach back into the esophagus can cause GERD. The second disorder is PUD, or peptic ulcer disease. It's also commonly referred to as a bleeding ulcer. This is a tear in the GI lining that exposes the vasculature to the acidic contents in the stomach and the GI tract. This is more severe and it warrants immediate treatment. The true prevalence of GERD is difficult to assess for a variety of reasons. First, patients do not always seek medical attention for GERD. There are over-the-counter treatments available, so many patients may self-treat. Additionally, symptoms do not always correlate with the severity of the disease. Some people may experience mild symptoms that do not interfere with their normal routines, whereas other people may have to change many aspects of their life because of GERD. What we do know about the prevalence is that it depends on the region and diet. So, it's highest in Western countries that have high rates of cholesterol, obesity, and diets rich in processed foods. But even within the same country, it can range. So, if you think about places that have more spicy foods, such as Cajun or barbecue areas, versus places in the country that have a more mild cuisine. It is estimated that 44% of Americans suffer monthly from GERD symptoms and that over 20% suffer weekly from GERD symptoms. But again, this is just an estimation since we do not have actual prevalence reported. Let's take a second to pause for a brief self-assessment. Thinking about what you may already know about GERD and what we've briefly covered in the introduction, which of the following do you think are common causes or triggers for GERD? Take a second to think about this and we'll go through the answer on the next slide. The options are coffee, obesity, smoking, or all of the above. If you answered all of the above, you were correct. Those are just 3 examples of common GERD triggers. We'll discuss a few more below. First, GERD can be triggered by dietary reasons. So diets that are rich in fatty foods, spicy foods, acidic foods such as tomatoes or orange juice, large meals, or alcohols can all be common causes of GERD. There are also lifestyle choices such as smoking or stress, which can increase your risk for GERD. Additionally, there can be anatomic reasons. So if you remember back to talking about anything that puts pressure on that lower esophageal sphincter can cause GERD. So thinking about pregnancy, tight-fitting clothing, and obesity are all putting pressure on the stomach, which can loosen that sphincter and cause the acidic contents to go back into the esophagus. Finally, there are medications such as aspirin and iron that can be irritating to the esophagus and to the stomach that can cause GERD, and medications such as amlodipine that can relax the esophageal tone and can allow contents from the stomach back into the esophagus. Finally, genetics can play a part in GERD. There's a rare disease called Zollinger-Ellison syndrome, which can cause the stomach to produce too much acid, which can be a cause for GERD. The symptoms of GERD mimic what you see in this picture. Patients often report a burning sensation in the abdomen and it can radiate into the chest. They may feel a warm sensation across the abdomen, especially near the stomach and the esophagus. These symptoms can often be confused with a heart attack. People who have never had GERD before may feel this burning in their chest and believe they are having a heart attack. Likewise, people who have had GERD before may ignore the symptoms of a heart attack and believe it is just another episode of GERD. It is common in the emergency department for patients to confuse GERD and heart attack symptoms. The increased acidic production can cause your body to produce more saliva, which is thought to help counteract the acidity of the reflux because saliva has a basic pH. Patients may also find that they are belching more often or that food feels like it's coming back up into the esophagus. If GERD is not treated, the complications can be serious and they can affect the patient's quality of life. Untreated GERD can lead to constant chest and abdomen pain, difficulty sleeping, eating, and exercising, and also worsening of asthma. If left untreated for a long time, GERD can lead to Barrett's esophagus, which is when the esophagus lining is eroded by the long-term exposure of acid. Barrett's esophagus can put a patient at risk of a 30 to 60 times higher risk of developing esophageal cancer. The following is a guideline for classifying GERD. It's more of an informal classification system, but this is generally used by providers and pharmacists to determine what kind of treatment a patient should use for their GERD. The classification system is based on severity and frequency of symptoms. Mild GERD is considered intermittent or sporadic flare-ups. Moderate GERD is when there are persistent symptoms almost daily. And severe GERD is classified by chronic pain that is also unresolved by fast-acting medications. And we'll review what some of those fast-acting medications are in a few slides. The biggest impact patients can make on GERD is limiting or eliminating triggers and risk factors. Lifestyle changes can be difficult to implement, but they are very effective. However, they may not entirely resolve the GERD symptoms, and medications may still be necessary. However, below is a list of effective lifestyle changes that patients can make to reduce their GERD symptoms. Weight reduction is important because, again, that reduces pressure on the stomach and the esophagus. Quitting smoking, wearing loose-fitting clothing, avoiding spicy foods or triggers. People often say to think of GERD food triggers as a big Italian meal. So an Italian meal covers a lot of the triggers. So if you think about an acidic tomato sauce, a glass of wine, that's the alcohol, chocolate cake, chocolate can be a trigger for GERD as well too. And then you think of a big Italian meal, so lots of food as well. They can also eat smaller and less fatty meals. They can raise the head of their bed and then avoid lying down after eating. The pharmacotherapy treatment for GERD is available both over-the-counter and prescription. The difference between over-the-counter and prescription is usually the dose and duration of therapy. Over-the-counter options are often available in lower dosages and are not recommended to be used longer than 2 weeks without talking to a doctor. Prescription medications are often higher doses and can be used more chronically. Because patients can buy over-the-counter medications to treat GERD, it is important to counsel patients on using the medications appropriately and safely. This includes knowing about other medications they may be taking and asking about lifestyle and symptom severity and frequency. There are 3 main treatment options for GERD. Antacids are very common, and maybe you've taken them yourself. They chemically neutralize the overly acidic contents of the stomach to bring the pH down. Once antacids aren't enough or symptoms occur more frequently, we can try other options, including the H2 receptor antagonists and the proton pump inhibitors. We will discuss all of these in more detail. 2 common examples of antacids are Tums and Maalox. Antacids work very quickly, but they do not last very long, and they do not treat underlying triggers or conditions. They work by neutralizing the stomach acid, which provides immediate relief. We will pause for another self-assessment. Which of the following medications do you think would be the best option for mild heartburn symptoms? Remember that mild means that the GERD is intermittent or there are sporadic flare-ups. The options are antacids, H2 blockers, or the proton pump inhibitors. While antacids can be used for all three levels of GERD, they are probably the best option for mild GERD since it happens infrequently and it's not that severe, and the antacids provide immediate relief to symptoms. While antacids are generally well tolerated, they can cause some side effects that patients should be aware of. They can cause constipation, especially the calcium carbonate, but some patients can find that they'll see the opposite of that and they will get diarrhea from antacids. There's also potential for drug interactions, especially with antibiotics and thyroid hormone medications and iron supplements. The calcium and the antacid can bind all of these medications in the stomach and make them less effective. There's also a rare syndrome called milk alkali syndrome, in which the antacids can reduce the pH so much that the whole body's pH becomes less acidic. The next step up from antacids are the H2 receptor antagonists such as Pepcid or famotidine or Zantac, ranitidine. These medications work by blocking the histamine receptors that turn on the acid pumps in the stomach. When the medication blocks these receptors, the histamine cannot bind and the pumps cannot be turned on. These medications are best used for more frequent or severe GERD. They can be used as prophylaxis if you have a known trigger. For example, if you know that spicy food gives you GERD, you may take a H2 receptor antagonist 30 minutes before you're going to have a spicy meal. These medications work pretty quickly, so you can use them proactively or reactively to GERD symptoms. These agents do have side effects, especially at higher doses. They can cause headache, fatigue, and dizziness. These medications can also cause anticholinergic side effects, which can be especially problematic in the elderly. Anticholinergic side effects include things such as sedation and cognition problems, which can cause severe issues in the elderly. Additionally, these medications are eliminated by the kidneys, so they can cause problems for people with low kidney function. There's a specific H2 receptor antagonist called cimetidine, which is not used that often anymore because it has many more drug interactions than the other medications available in this class. The final option are the proton pump inhibitors, or the PPIs. These include Prilosec and Prevacid. Again, these options are available both over the counter or by a prescription. They work by completely shutting down the active acid pumps to reduce the amount of acid present in the stomach. This medication permanently deactivates the pumps, so it takes 3 to 5 days to see the full effect of this medication, since it takes a while for the pumps to be deactivated. These PPIs will not do anything for immediate relief of GERD symptoms, which is an important counseling point. These medications can also be used in stomach bleeds and peptic ulcer disease, which we will discuss later. The side effects for PPIs are not very specific and include things such as headache, dizziness, diarrhea, constipation, and nausea. Some patients may report feeling like their stomach feels more upset or gassy the first few days they start taking the medication, but that often goes away. Now that these medications have been on the market for a while, there are some concerns about their long-term use. One big concern and counseling point is gastric acid rebounding. If a patient takes a PPI for more than a few weeks in a row, when they stop taking it, their body is likely to overreact and produce even more acid, and they may get rebound reflux. This is why it is important to not take the medication for longer than you need to. Also, the long-term use of PPIs is associated with an increased infection risk such as C. diff, because the acidity of the stomach is one of the biggest defense mechanisms from infection. There are also reports that the long-term use can cause neurologic damage because of a vitamin B deficiency, because the body needs an acidic environment to absorb vitamin B appropriately. This is also the same mechanism that may be linked to increased fracture risk, because the body may not be absorbing calcium as well in the low acid environment. I would expect to see a lot more research on long-term PPI use in the years to come. Next, we will switch gears and talk about PUD or peptic ulcer disease. Again, the prevalence of PUD varies between age, gender, and geographical location. PUD used to be predominantly seen in men, but now there's more of an even split between men and women. It's estimated that 60 to 100% of ulcers will recur within 1 year of their initial ulcer healing when treated using conventional anti-ulcer regimens. Common causes for PUD include a bacteria called Helicobacter pylori or a H. pylori infection, nonsteroidal anti-inflammatory drugs, or NSAIDs, which we'll talk about in the pain module. These drugs can increase the risk of GI bleeds and diminish the ability for the GI tract to regenerate. Also, smoking and stress can also be common causes of PUD. Take another brief pause for a self-assessment to think about which of the following are signs or symptoms of PUD. Remember that at the beginning of the lecture, we talked about PUD being a bleeding ulcer or a tear in the GI tract. We will briefly review some of the signs and symptoms of PUD. Remember, in ulcers, there is a tear in the lining that goes deep into the mucosa, and this is associated with bleeding. The blood and the vasculature are touching the acidic contents of the stomach and the GI tract, which can be very painful. This pain can cause sharp abdominal pain. It can also be difficult to eat since the food can turn on the production of more acid, so there can lead to nausea, vomiting, or a loss of appetite. Finally, there can be dark, tarry stools. When blood gets into the GI tract, this blood becomes oxidized and turns into a dark and tarry consistency. It is often also called coffee ground stools. This slide is just an FYI for your information. It's talking about how ulcers are named based on their site of bleeding. So an ulcer in the small intestine is called a duodenal ulcer, and an ulcer in the stomach is called a gastric ulcer. You'll also see in the top there's one in the esophagus, and that would be an esophageal ulcer. So again, with PUD, the first thing you want to do is look at lifestyle factors or triggers that you can eliminate. This includes things like smoking and certain medications such as NSAIDs or bisphosphonates, which are an osteoporosis medication. If you can, you want to remove anything that's causing the ulcer or making it worse. Next, if the ulcer is caused or infected by the H. pylori bacteria, you're looking at what's considered the gold standard of a 3-drug regimen that usually consists of 2 antibiotics and a proton pump inhibitor. The 2 antibiotics are usually clarithromycin and amoxicillin, but you may see different ones depending on allergies or local bacterial sensitivity. The antibiotics eradicate the bacteria, and the PPI helps reduce the stomach acid so that the lining of the stomach or intestines can heal. Finally, Carafate provides pain relief because it forms a waxy matrix that covers the ulcer site, so there's protection between the ulcer and the contents of the stomach. This reduces the irritation of the ulcer and allows the ulcer site a chance to regenerate. In summary, GERD is a very common disease in the United States, and the treatment is based on the severity and frequency of the condition. Antacids work by chemically neutralizing the acidic environment of the stomach. H2 receptor antagonists block the histamine receptors that inhibit histamine from turning on acid pumps, and the PPIs shut down the pumps completely. If GERD and PUD are not properly treated, there can be severe consequences, so it is important that patients are properly educated on the lifestyle modifications and risk factors for GERD and PUD. PUD is generally more painful than GERD and may require the use of an antibiotic to eradicate a bacteria associated with ulcers.